start with the most common cause of proptosis, that is thyroid eye disease. It is the most common disease affecting the eyeball, the proptosis. Okay, most common disease affecting the orbit. It is more common in females. It is basically an antigen antibody reaction. It's an antigen antibody reaction where anti-thyroid antibodies, they have a cross antigenicity with the extraocular muscle protein. Okay, when these anti-thyroid antibodies, they go into the extraocular muscles, these antibodies, they cause adipogenesis and hyaluronic acid synthesis, leading to the tendon sparing muscle belly enlargement. Okay, there is enlargement of the muscle bearing, muscle belly, and there is on both sides the tendon is absolutely normal. Only the muscle belly is enlarged, tendon is spared. Okay, this is very characteristic. This is the antigen antibody reaction. The clinical features which the patient present are eyelid signs, von Graffi sign, lid lag, which are there. There is soft tissue involvement, there is kind of ecchymosis. Proptosis, all types of proptosis can be seen. It can be axial, upward, downward, any type of proptosis, unilateral, bilateral, any type of proptosis can be manifested. Okay. Optic neuropathy, which is because of compression, and exposure keratopathy, the eyeball is so pushed forward that the lid is not able to close over the cornea, leading to exposure of the cornea, leading to keratopathy that is there, and strabismus because of involvement of the extraocular muscles, there is strabismus. Talking about the eyelid signs, the most prominent sign that is there is von Graffi sign. Easy way to remember is wo, go, slow. Okay, so the lid, when we look up and when we look down, the upper lid is supposed to follow the eye. So here what is happening? Here the lid is going slow. It is not following the eye. So there is a lid lag on down gaze, and the patient looks up and the patient looks down. The eyeball goes down, but the lid goes a little later. There is a lid lag. There is a time gap between the eyeball movement and the lid movement. Okay, this is. Next is Dalrymple sign, that is lid retraction. That is like this. There is upper lid retraction and there is upper scleral show. The upper white part is visible. That is Dalrymple sign, as if the person is scared. So that is Dalrymple sign. Stellwax sign is infrequent blinking. That patient is looking straight and is not blinking. So this is how you can remember. Stellwax sign is looking like this, is staring. Okay, Stellwax you can remember by this. So these are the upper lid signs which are there. Next are oculomotor related problems. As I was telling you, there is squint can manifest. The first muscle to be involved is inferior rectus, followed by medial, followed by superior, followed by lateral. The easy mnemonic to remember is I am slow. Okay, inferior, medial, superior, lateral, and slow. Everything is slow. Patient is hypothyroid, so everything is slow. That is how can you remember the extraocular muscle involvement. Next is proptosis, exophthalmos. It is axial. It is the most common cause of both bilateral and unilateral proptosis. It does not depend upon the thyroid status. Please remember, this is an antigen antibody reaction. The antibodies are getting formed against the thyroid gland. These antibodies are they are attacking the extraocular muscles. Now, these antibodies have got no relation to thyroid hormone status. It is not thyroid hormone which is getting affected. So, even in patients who have a euthyroid status can have this antigen antibody reaction patient can present. And controlling the thyroid levels has got nothing to do with antibodies getting formed. So, the treatment is to be titrated absolutely separately as compared to the thyroid treatment. Okay. Optic neuropathy is a compressive optic neuropathy because of the swelling up of the extraocular muscle. The optic nerve is getting compressed. The muscle is compressing on the optic nerve. This is how a compressive optic neuropathy is happening. It is not an optic neuritis. There is no inflammation of the optic nerve. Please remember that. Treatment, as is very, very obvious, it is titrated to the antigen antibody reaction. Antigen antibody, you have to give, what do you have to give? You have to give steroids. Okay, that is very, very obvious. And you can give radiotherapy, radiation can be given to control. For controlling the exposure keratopathy, you have to give lubricants. In case it is required, you have to suture the two lids. That is called as tarsography. Tarsography, suturing of the two lids to save the cornea from exposure. In case the eye is still not getting solved, then you have to go into orbital decompression. That is, you have to release the pressure of the orbit. How do you do that? By removing the medial wall and the floor. This is called as a two-wall decompression. It is indicated where steroids and radiation have not been effective and there is compressive optic neuropathy, or there is gross exposure keratitis and corneal ulceration, and there is fear of losing the eyeball. So there, in decompression, you remove the walls of orbit to create the space for the swollen extraocular muscles. First, in two-wall decompression, you will remove the medial and the floor of the orbit. Medially, you have the ethmoid sinus, and the floor, you have the maxillary sinus, which is there. In case the eye is still not going in case there is still a lot of exposure which is happening, then you remove the lateral wall. In case it is still not getting control, then you remove the roof also. That it is called as three-wall and four-wall decompression that can be done. Okay. So this is what is thyroid eye disease, on which many questions are